Hey guys, this is Dr. Akshaya. I'm here to discuss few important topics from oral medicine and radiology that will have a high weightage in NEET exams. So this video will be discussing about leukoplakia and its management aspects. What is leukoplakia? So leukoplakia is a white patch. So leuko means white and plakia means patch. So leukoplakia is a white patch and it was defined by WHO as a white patch that cannot be characterized clinically or pathologically as any other disease. So meaning that it's a diagnosis of exclusion. So any definable clinical presentation or any etiological factors that is present other than tobacco, it should not be diagnosed as leukoplakia because it should be diagnosed only after excluding all the other definable lesion. So why leukoplakia is more important? Because it is considered as a potentially malignant disorder. That means in few years leukoplakia can transform into oral squamous cell carcinoma and it has a higher potential rate than any other potentially malignant disorder. So before going into depth about leukoplakia, I just want to clarify few important concepts. So the reason why white lesions appear white. So first is due to hyperkeratinization. Second, due to increase in the thickness of the spinous layer of the epithelium, which masks the underlying vascularity. Third, extracellular accumulation of fluid component. And fourth, the microbial organisms such as candida can result in pseudomembranous slough formation. So out of four, the first three what I mentioned is non-scrapable, but the fourth component will be scrapable because of the pseudomembranous slough that will be adherent to the mucous membrane. So the leukoplakia what we are discussing here will be due to hyperkeratinization and increase in the thickness of the epithelium, which further go into a dysplastic features. Coming to the etiological factors that is associated with the leukoplakia. So tobacco is the most important factor according to the WHO definition itself, and other factors such as alcohol and sanguinea mouth rinses, UV radiation and microorganism association are synergistic factor for the development of leukoplakia. In microorganism, the candida can result in superimposition over the leukoplakia, or it can result in chronic hyperplastic candidiasis, which is called as candida leukoplakia. So either way, if the leukoplakia is associated with microorganism, it has an increased risk for malignant potential. So it has to be treated cautiously. Clinical features of leukoplakia. It is commonly seen in men and who are chronic smokers, smoking BDs or cigarettes, and 40 years of age. So the site of involvement usually buccal mucosa, lip commissures, and then lateral borders of the tongue and vermilion borders of the lips and floor of the mouth. Knowing the site of involvement is very necessary in determining the treatment plan or determining the prognosis, because certain sites such as lateral border of the tongue and floor of the mouth are considered as an high risk site for malignant transformation. Coming to the clinical presentation of leukoplakia, so there are two gross presentations that could be observed in leukoplakia. First, homogeneous, where we could see the uniform color and texture. Another presentation is non-homogeneous, where we could see the mixture of red component and also variation in texture such as nodular or fissurated or papillary projections. So the difference what we have to know here is the uniform pattern or homogeneous pattern has a less risk for malignant transformation, whereas in case of non-homogeneous pattern of leukoplakia has an higher risk for malignant transformation. So when the leukoplakia has a mixture of erythema component or red component, it is called a speckled leukoplakia, or if it has a papillary projection as we are seeing now, it is called as proliferative verrucous leukoplakia. So now we have seen the site and clinical presentation, and based on that we have to diagnose the condition and provisionally diagnose it as leukoplakia. So if we cannot identify any etiological factor, then we can give it as a leukoplakia itself and then going for a biopsy. So if the lesion is less than 2 cm, we have to go for an excisional biopsy. If it is more than 2 cm, we have to go for an incisional biopsy. What do we see in the biopsy or histopathological picture? So I have included a picture here that shows the transformation from normal mucosa to malignancy. So here we could see the thin smooth leukoplakia. In histopathology, we could see the hyperkeratosis, that is increase in the thickness of the keratin layer, and then increase in the thickness of the spinous layer, which is known as acanthosis, and because of the inflammatory component, occasional lymphocytes are seen. So this is the homogeneous type of leukoplakia presentation in histopathology. Then going to the thick fissured leukoplakia, which is non-homogeneous leukoplakia. Here there will be variation in the texture alone. Here we could see hyperkeratosis, acanthosis and mild or moderate dysplasia. So the non-homogeneous pattern starts with the mild or moderate dysplasia. Then it is going to the proliferative verrucous type of leukoplakia. Here we could see moderate to severe dysplasia. Then after which there will be epithelial atrophy and severe dysplasia, and it can result in carcinoma in situ, where the dysplastic feature is present entire epithelium, but it would not invade the connective tissue. So once it invades the connective tissue and crosses that line, it is called as oral squamous cell carcinoma. Now I think you get the point why leukoplakia is considered as a potentially malignant disorder, and how from normal mucosa it goes into erythroplakia, then it goes into oral squamous cell carcinoma. Coming to the management aspect of leukoplakia, like any other disease, identifying the cause and eliminating it will be the preliminary management part in the leukoplakia. So first we have to identify if there is any sharp tooth that is creating this type of white lesion. So the sharp teeth can result in hyperkeratosis, that is called as frictional or traumatic keratosis. So we have to identify any sharp teeth is present, then we have to go for coronoplasty. Then the patient's smoking history should be assessed, and patient should be advised for tobacco cessation counseling. Then as I said, there will be superimposed candidal infection or chronic hyperplastic candidiasis. So in order to differentiate that, we have to prescribe antifungal, that is 1% clotrimazole 3 to 4 times daily for 14 days. And then we have to advise the patient for a professional scaling. This will motivate the patient psychologically to undergo tobacco cessation. After doing initial management, we have to wait for 2 weeks to notice any changes in the regression of the lesion. So if there is any regression in the size, then we have to manage conservatively. If there is no regression of the size, then we have to go for a biopsy and seeing the histopathological features. If there is any dysplastic feature is present, then we have to go for surgical approach, then combining with chemopreventive approach. First, we will be discussing about conservative management of leukoplakia, where we will be using chemopreventive agents and antioxidants to prevent the neoplastic transformation. So, lycopene and beta-carotene are the most common agent that was used in leukoplakia, and it is rich in antioxidants, and it also acts as a free radical scavenger and neutralizes various reactive oxygen species. So, based on this mechanism, it inhibits the neoplastic cellular transformation and halts the progression of cancer. The beta-carotene and lycopene are available both in topical and systemic formulation that we routinely use in leukoplakia management. Next, chemopreventive agent what we are going to discuss is vitamin A and its analogs. So why vitamin A in leukoplakia is, it helps in cell growth and cell differentiation, and it also acts as a keratinolytic agent. Thereby, it is preventing hyperkeratinization and helps in combating the dysplasia. So these two features makes an ideal way of using vitamin A in the management of leukoplakia. So here also, like lycopene and beta carotenoids, we have both systemic and topical formulation, but it should be used cautiously because it can cause teratogenicity in pregnant women, and also since it's a fat soluble vitamin, it can result in hypervitaminosis or toxicity. So the topical formulation that is currently used is 0.05% and 0.1% for 3 to 4 months. Next chemopreventive agent is fen-retinoids. The fen-retinoids is a vitamin A analog which inhibits the cell growth by apoptosis. So it is also used as a topical formulation in combating the leukoplakia. Next chemopreventive agents is vitamin E. So vitamin V, as we all know, it has an higher antioxidant potential. It inhibits the lipid peroxidation and helps in combating the cancer progression. And it also acts as a free radical scavenger. And we have to cautious about the hypervitaminosis and toxicity as in case like vitamin A, because it is also a fat soluble vitamin. Next chemopreventive agent what we are going to discuss is bleomycin topical preparation. So bleomycin is not routinely used in leukoplakia, but it can be used as an adjuvant in surgical approach. So why it is used as an adjuvant in surgical approach means, so we have all heard about debulking. So if there is any diffuse leukoplakia and if you want to go for a surgery, you will result in large mucosal defect, and also you will need of grafts in order to cover it. So in that situations, we can use topical bleomycin and it decreases the size of the lesion. Then you can go for surgical approach. So this is mainly used as an adjuvant in surgery but not routinely used because of its side effects. So next chemopreventive agent what we are going to discuss is curcumin. So curcumin in the capsule formulation 4000 to 8000 mg per day was used in the treatment of leukoplakia, and it has been shown that 20% clinical resolution has been achieved. Recent modality of management of leukoplakia includes photodynamic therapy. So the photodynamic therapy where we use photosensitizers of particular dye and which is applied directly to the lesion. In case of leukoplakia, it can be given topically and exposed to a particular wavelength of light, resulting in photochemical reaction. So these photochemical reaction results in tumor ablation and ischemia, thereby preventing the angiogenesis and apoptosis of the tumor cell. So this reaction is caused by variety of reactive oxygen species and singlet oxygen molecules. In leukoplakia, the most common photosensitizer that was used is 5-aminolevulinic acid along with the combination of 630 nanometer red wavelength of light, which can produce 0.5 centimeter tissue penetration. So this, based on the wavelength of the light, the tissue penetration differs. So here if we use 630 nanometer of red wavelength, we can penetrate the tissue up to 0.5 centimeter. If at all we use blue wavelength of light, it can be the tissue can be penetrated only 1 mm. So based on the wavelength of the light, the tissue penetration depends, and based on the size of the lesion, we have to modify it accordingly. Next, coming to the surgical management of leukoplakia. First, surgical excision. So if the lesion is 2 to 4 centimeter, then we can go for excision. If it is large defect, we have to combine it with the grafts, or if it is smaller defects, we can achieve secondary healing. Another mode of surgical approach is electrocoagulation surgery, where we give extreme thermal temperature to ablate the tumor cells or leukoplakic lesion. So next advanced modality in the treatment of leukoplakia from the surgical point is cryosurgery, where we use liquid nitrogen that can create extreme low temperature that results in ischemia and dehydration of the tissue and resulting in tumor ablation or excision of the leukoplakic lesion. And the last modality what we can use in leukoplakia is laser ablation or laser evaporation. Either using a carbon dioxide laser in a defocused mode or continuous pulse mode, we can achieve this laser ablation and evaporation. The disadvantage of laser ablation, cryosurgery or electrocoagulation procedure is the tissue will not be used for histopathological examination. So the one thing that we have to keep in mind. So coming to the end of our video, so the degree of epithelial dysplasia determines our treatment plan. So we have to know the site of the lesion and also the size of the lesion, whether it is having a higher potential rate for malignant transformation, either by histopathological examination. Then we have to combine the surgical and conservative approach, appropriate management to the patient. That's all about leukoplakia, guys. I think I have given a clarity about leukoplakia and its management from neat aspect. Kindly go through it, and thank you.